Okay, good morning and welcome everybody to Global Grand Rounds. My name is Alexa, and I just briefly want to chat with everybody about CME, so continuing medical education. If you're watching this live, you can click on one of the links I just put in the chat. It's the second link and you can go get your CME credits there. If you are watching this recorded and it's a week from November 9th, you can still go to that link and get your CME credits. I've also pasted in the chat our link to our page for Global Grand Rounds in case you want further information. I'll also put my email in the chat if you'd like to reach out to me. And then finally, I have pasted in the chat a YouTube link to Dr. Hruby's last Global Grand Rounds presentation over a year ago. That was on osteopathic medicine. So if you're interested in checking that out, please feel free. But in the meantime, thank you again for joining us. I still see we have a few people still joining us here. I'll just repeat the CME spiel again at the end just in case, but I will turn it over to Dr. Pecchia.
Thank you, Alexa, and great to be here with everyone again. Wanted to start by introducing our team. First, Alexa, thank you so much for all your hard work on behalf of Global Offsite Care and for leading the Global Grand Rounds team and for your years of service to the organization. Just amazing, and keep up the great work. Our guests today, our guest speakers, Madeline Shaver, fourth year medical student at Western University of Health Sciences and at the Pomona Medical School campus of the College of Osteopathic Medicine Pacific. She will be leading our case presentation today, and then we'll introduce Dr. Hruby, who Alexa mentioned earlier, who returns to then demonstrate the follow-up care to the patient who is the focus of this case, which, as you may notice later in the presentation, is yours truly. So this is an ongoing actual case, and with that, I'll finish the introductions with myself, the medical director, Gregory Pecchia, of the Global Offsite Care's organization, as well as the co-director with Alexa and her team of Global Grand Rounds. And I'm a geriatrician by training and currently serve on the faculty at Western University College of Osteopathic Medicine in the role of a telemedicine director and course director for telemedicine at the university. So with that, I will hand it over to Madeline Shaver, and we'll go from there. Madeline.
Wonderful. Thank you so much. Pleasure to get to speak with you all today and present our case of the remote diagnosis and management of a hidradenocarcinoma and its complications. Go ahead and move to the next slide. So introduction to our case today. So we have a patient who is a previously healthy 69-year-old Caucasian male, presented via telemedicine encounter to his dermatologist with concern of 5-year history of a painless, slowly growing mass of the left elbow. Next slide, please. Wonderful. So a little bit more about our case history. As previously discussed, 5-year history of a slowly growing, painless, but movable left elbow mass. Patient has no other complaints at this time. Past medical, surgical, family history, and social history were unremarkable, save for history of well-controlled hypothyroidism and history of repeated superficial elbow trauma with 3 episodes of associated infective olecranon bursitis over several decades, secondary to surfing. Review systems included polyarthralgia, general weakness, night sweats, numbness, muscle weakness of the limb, and hand pain. Patient's history and symptoms were input into the AI-driven Cahoon chatbot differential diagnosis support system to generate an initial differential. Next slide, please. Right, and here's a little bit of a breakdown of the AI-generated differential diagnosis. The most likely diagnosis was considered to be rheumatoid arthritis, secondary dermatomyositis, and less likely included tuberculosis, sarcoidosis, tumor of the lung, and secondary malignant neoplastic disease. And next slide, please. Examination findings on this patient included a demonstrated painless, well-circumscribed, freely movable bean-sized mass of the left elbow, and the remainder of physical exam findings are unremarkable. Next slide, perfect. So the AI-generated workup recommendations included plans for both laboratory studies and imaging. Imaging included muscle biopsy, EMG, MRI, ultrasound of the affected area, and radiography. Laboratory studies that they recommended included inflammatory markers, aldolase, CK, myoglobin, iron studies. Next slide, please. So actual case workup included a variety of laboratory imaging and biopsy studies. Laboratory workup, including CBC, sedimentation rate, CMP, and TSH, were unremarkable. Imaging studies included plain film of the left elbow, which appeared benign, save for some noted soft tissue swelling. Patient did undergo a biopsy of the area, which did demonstrate hydradenocarcinoma with a recommendation for Mohs excision. And prior to excision, a patient underwent preoperative whole body PET CT, which was benign, save for some reactive changes to the left dorsal soft tissue swelling in the left olecranon area. Also noted were multiple likely benign pulmonary nodules. And next slide. Initial excisional findings. Patient did undergo the Mohs excision of the hydradenocarcinoma with clear margins. However, same-day oncoplastic surgical closure with an additional biopsy did show deeper tumor involvement with skip lesion adjacent to underlying bursa in the bony margin. And next slide. And then following the results of this, the patient did seek 5 separate opinions over the course of 6 weeks, which included both on-site and off-site consultations and significant usage of telemedicine encounters for the follow-ups, the variety of centers of excellence throughout Southern California and also at the Mayo Clinic. Treatment recommendations were wide, as this is a rather rare diagnosis, and included everything from wide radical excision of the entire area to less invasive, more watchful waiting methods. After weighing a variety of options, the patient did elect to pursue radical excision to the bone with reconstruction, followed by serial supradiaphragmatic contrast CTs twice yearly for about 3 years, followed by yearly exam and CT. Current case status, patient is currently stable status post-surgical intervention. Chest CT remains benign, appearing post-operatively with additional benign quarterly examinations and plain films. So currently, the patient is experiencing some complications related to their surgical intervention with postoperative wound adhesions and slight residual MSK dysfunction and resultant mild left elbow and shoulder girdle pain. Patient is now seeking follow-up with our primary care osteopathic physician, Dr. Hruby, for continued medical follow-up and general medical screening and assistance with the left-sided elbow and shoulder dysfunction. And next slide, please. And before we jump into the osteopathic evaluation of our patient, I'd like to take a minute to discuss hydradenocarcinoma. Hydradenocarcinoma is a rare malignant adnexal tumor of eccrine sweat glands, mostly observed in the head and neck, but have often been observed in the extremities and the trunk as well. Tumor incidence accounts for about 0.05% and makes up only 6% of all malignant eccrine tumors. It also goes by several other different names, including malignant nodular and clear cell hydranoma, malignant acrosporoma, and others listed here. Next slide, please. Thank you. So diagnosis is confirmed histopathologically and with immunohistochemistry. The clinical presentation of this disease is often isolated, hard and asymptomatic intradermal nodule, often on the head and neck as discussed. The mass is often very slowly growing and can be erythematous or violaceous in color. An initial lesion may also appear as an erythematous and slowly growing plaque. Diagnosis, as discussed, is made with histopathology and immunohistochemistry of a biopsied specimen, and the histologic criteria for diagnosis include a lack of demarcation, an invasive growth pattern, a deep extension of the tumor, nuclear pleomorphism, necrosis, vascular invasion, perineural invasion, and presence of increased mitoses. And to the left, you see an example of hydradenocarcinoma histology. Next, please. Next slide, please. Thank you. And I have here another example of what this might look like on a slide. And this image is from Ghaffari et al.'s July 2022 case. Next slide, please. Thank you. The clinical course of hidradenocarcinoma is currently limited given the rarity of the diagnosis and the very few clinical studies delineating the expected disease course. Many of the studies do show that hydrocarcinoma to be an aggressive malignancy characterized by frequent local recurrence and metastases. One of the more recent reviews that I was able to find was a 2015 review by Sony et al., which estimated a post-surgical recurrence of about 10 to 50% of the tumor and a 5-year post-surgical survival rate of less than 30%. However, many of these studies really draw from very limited sample sizes and was one of the primary limitations of this particular review. A more recent study by Gao et al. This year in the Annals of Medicine with a sample population of about 248 patients suggests that it has a far better prognosis than previously thought. They estimated that their overall 10-year survival rate for patients and CSS rate were 60.2% and 90.5% respectively. However, further studies right now are required to develop a stronger body of evidence regarding the clinical course of this particular disease. And next slide. So the differential for hidradenocarcinoma include hemangioma, lipoma, lymphangioma, other malignant skin cancers, including basal cell and squamous cell carcinomas, and other malignant adnexal carcinomas, including other eccrine adenocarcinomas. And next slide. And treatment, right now, there is currently no definitive agreed upon treatment course. However, surgical excision is often considered the mainstay. Surgical treatment options really do encompass a wide variety of particular procedures, including a wide local excision or Mohs surgery. With wide excisions, 3-centimeter margin is recommended, and sentinel lymph node mapping and biopsy may be appropriate, considering this tumor's particular propensity to spread along lymphatic channels. Surgical intervention may often be followed by additional treatment modalities, including chemotherapy and radiation. And next slide. Surveillance and follow-up for this tumor. Sources really differ on the recommendations for surveillance and follow-up. However, there is pretty universal agreement that patients should be very closely monitored following surgical intervention and diagnosis of this disease with imaging. Given the rarity of tumor, further studies are also required to develop improved evidence-based surveillance guidelines at this time. And next slide. So here are references for our presentation today, and the patient, go ahead, next slide. Perfect, and the patient now presents today with osteopathic primary physician, Dr. Hruby, for follow-up regarding the postoperative complications of his surgery, which include that left elbow and left shoulder girdle pain as previously discussed. So I'd like to turn this over to Dr. Hruby.
Thank you, Matt.
Good to be back here.
It's great to see you.
It's been a long
Sit down, and I'll sit
long
next to you.
time. In fact, why don't we switch sides here? So, yeah, I'll sit here.
Okay.
And let me get my bag out there. So, okay. Yeah, so you got the reports about the adventure of that I've been through.
Yes.
And yeah, and the surgery on the elbow was a success.
Mm-hmm.
And it's now been about a year.
Okay, that was going to be my next
Coming up
question. How exactly how long? Yeah, I thought so. Yeah, that's good.
Yeah, so I'm just so glad to be back here.
Yeah.
And I really appreciate the work that you did in the beginning to kind of get me referred out.
Sure.
And but I really would like to be able to stay under your care for follow-up, and also to deal with some of the residual issues that I have with this elbow.
Sure. Yeah. Well, there's no reason why we can't be sort of the central point for your care now at this primary care place where I know you're comfortable, and we can proceed with those kind of things.
Absolutely.
And certainly work with you and make sure that any needed follow-ups get taken care of, or anything else that turns up gets taken care of properly. What follow-ups are planned for you at this point? Anything soon?
If I remember correctly, and it's it's accessible in the medical record that align with your medical record here, but basically an exam every 3 months.
Right. Mhm.
And any indicated
Sure.
rehabilitation, which is one of the things we'll, hopefully address today.
Yeah.
And
Mhm.
then every 3 months to 6 months, depending. Right now, it's twice a year scans,
Right.
CT scans with contrast of my chest.
Right.
And then every 3 months, a plain film of the elbow to
Mhm.
take a close look at the bone.
Yeah.
Because the tumor was
Right.
sitting right on the bone.
Yeah.
And,
Mhm.
yeah, that's about it.
Sure. Yeah. Yeah. That sounds pretty standard actually for, follow-up. So good. Okay. How's everything else? Are you back to work a little bit? Or
I'm good.
Yeah.
Yeah, everything seems to be going along fine.
Mhm.
I've been working out, get back in the water.
Okay. Yeah.
Went on a surf trip a couple months ago.
Oh,
and
great.
In
Okay.
a hurricane and
Okay.
survived that. So I guess I'm doing okay.
Okay. That sounds great. That sounds great. Yeah.
Depois de eleger, vou fazer um dia para tirar aí vou fazer do começo
I don't think that. Okay.
So
Okay. So how are you feeling in general? I mean, usually, or not uncommonly, something like this is quite a
yeah,
hit to people, no matter
only-
what, as
only-
physicians, we know about this stuff, but that doesn't make any difference when you're a patient.
yeah, right. Yeah, it doesn't. And
Yeah.
so the only issue is some restriction
Okay.
of motion at the elbow, sense of pulling, and when I
Okay.
flex that like a fibrosis of some sort,
Yeah,
maybe.
yeah.
And then it goes up and I can feel that kind of pulling all the way down through my shoulder, down into this area, and sometimes, up into the neck,
Yeah.
where the shoulder connects to the neck.
Mhm. So it sounds like it's not so much painful, but more just sort of a
Correct.
annoying restriction in movement.
That's right.
Okay.
That's
Okay.
right.
All right.
Yeah. So I thought with your orientation and
Sure.
some of the stuff that you worked on me before with your
Absolutely.
hands,
Yeah. Yeah. No, we should
might
be able
be
to.
just
Yeah. Sure.
helpful.
Yeah. Well, I know in the past you've had some episodes with your bursa and the elbow, and now with the surgery and stuff. And of course, surgery is, I'm not sure how I want to phrase it. With all due respect to the wonders of surgery, it is a kind of a trauma in a sense. And from an osteopathic point of view, we know that even though you heal well and do well, of course, you're pretty functional. We know these kind of things can be in there, and it's part of the process. We get some, as people would say, scarring or fibrotic kind of feel in the tissue. And actually, what I'm thinking right now, among other things, is we'll check everything here, but the fascia, the supportive tissue of your body is everywhere. And so just the way you move when you describe it, I can tell we probably have some restriction, probably even from up in here down even through there. And so if we can work on that today and get some mobility in there, and then we can talk about some things you can do yourself, and then maybe need to work on this periodically a little bit, but I think we can, get rid of that little, it's an irritative thing, and it does get in the way sometimes, no matter how minor it seems to look and feel for the most part.
I'm
We're always
ready.
kind of working against it. Yeah. So, okay. I'm going to start with I want to look up in your neck and upper back here to start with, and see how the vertebral motion is, and maybe we can turn a little bit to see how the audience gets a little shot.
Maybe that way?
Yeah, that's fine. That looks good. So I'm going to look for vertebral motion restriction to start with more, because it can come along with a lot of this kind of stuff. And what I'm feeling for is gently kind of feeling the muscles and tissues around the cervical vertebrae here, and also gently motion testing these individual vertebral segments. And feeling a little bit of hypertonicity here on your right side in this very upper cervical area, probably around C2 or so. I'll move that. That's a little bit. And this is a little bit better. So if I go back this way, it's a little bit more tense. Let's just take care of that a little bit. I'm going to move your head just a little bit in these directions. I'm going to ask you to push your head against my hand and hold it like that. And relax. Good. So what I'm doing is push again. Each time I move it to what we call a barrier to the motion, the tissues that are tense there, and you contract them and then relax them. And when you relax, I can now stretch them a little more and move the vertebral segment a little bit more in the direction that we need it to go. Doesn't want to go to your left as well as it should. Push again. And relax. This is what we call a muscle energy technique. It's an isometric type of technique. And it's based on the idea that if I position your vertebral segment to what we call a barrier, it will rotate towards your left so far, and then I can feel that it tightens up. When you contract at that point, you tense up the tissues for 5 or 6 seconds, and then when you relax it, I can move a little farther. And usually 3 or 4 repetitions of this done in this fashion, in a controlled, localized fashion, tends to improve that motion. And I know it's not something that our audience can see, but palpating it again right now, that kind of tightened hypertonic area right over that segment is now much softer, and mobility is better. So and I'm going to palpate for the moment, since we're right here in this area, my fingers in front of your trapezius muscle on each side, and I'm palpating on top of the first rib on the side. So let me have you take a deep breath in once. And good. And again. And so what I'm feeling here is when you breathe in, your ribs tend to elevate here, the first ribs on each side. And when you breathe out, the rib on your right side descends like it should in exhalation. The rib on your left side tends to stay. One of the things that this relates to is that the first rib area here and this fossa area here is, as we know, major area where venous and lymphatic drainage returns to the body. So if there's this little motion restriction, it doesn't feel like much, but with all the dense tissues in there, it can tend to, even in a slight way, impede some of that venous and lymphatic return. And that can reflect itself in feeling, if not visibly swollen in your arm, that sort of feeling as though you have that kind of tightness, tension around you.
Right.
So,
and Doc, for the audience to be able to see a little bit better, maybe we could just get, you could see
I could
just a little bit to
Okay.
to your right, just
Yeah.
to make sure they got a good view of that. Yeah.
So what I'm going to do here is, with my finger pads on your rib, I'm going to move your head towards the rib this way and relax all these muscles here that attach down onto that area. And I can, with my fingers, I can move the rib inferiorly towards its exhalation position as far as I can until I get resistance. And I'm going to have you push your head into my hand again. Now, what you're doing here is you're contracting all the muscles actually on the right side of your neck. But while you're doing that, we're getting what we call reciprocal inhibition. The muscles on your left side need to relax in order to let these contract on the right. And relax now. And when you relax, I can now move your head over, and with my fingers, I can move the rib farther into exhalation. Push again. And relax. Good. And once more. And relax. Okay. Good. And let's have you go ahead and take a deep breath in again once. And out again. Okay, now we have a more symmetrical motion of the ribs here. So physiologically, what we see is by removing this musculoskeletal sort of restriction to this venous and lymphatic drainage area, we tend to improve the ability for these fluids to move through this area and drain a little bit more properly. And if we look through your thoracic region, it feels pretty good through here. I think a little bit of hypertonicity over this segment here. Looks like about 7 or 8 on your left side here. So, so this vertebra, among other things, is rotated a little more to your left, and it's not going to want to move to the right quite as well. It's not a major deal, but again, it's just another restriction in here. So what I will do is I'm going to palpate over those transverse processes at that segment and bring your head forward. Okay. And backward. Actually, I'm going to need to tilt you back a little bit like this. There we go. Okay. So I'll need to bring your head and shoulders. In fact, I'm just going to reach around you and bend you forward until I feel motion right here at this segment. And I need to rotate you and kind of bend you a little bit here. I'm going to ask you to turn your, actually what I'm going to ask you to do is with your right shoulder, you would push your right shoulder towards the ceiling. And relax it, good. And I'll take up some more movement here, push again. And relax, good. And again. And relax. There, okay. Yeah, these are all what we call muscle energy isometric techniques. Now we have a little better motion too. That I can motion test it again just quickly and make sure that I increased the motion and made some improvement there. Good. Okay. All right. Let's turn you around facing me again now, Greg, and we'll work on this shoulder and arm itself. And so we'll work our way out to the periphery here a little bit.
And for those watching, my friends out there, I've neglected to introduce you, my doctor today. Also, your background as a fellow of osteopathic physician, trained in Maine, I believe.
Yes,
in New
right.
England, and specializing in family medicine as well as osteopathic manual medicine
Right.
technique. And you are a fellow of the American Academy of Osteopathy.
Yes, that's our national organization, our specialty organization, if you will. Yeah.
And a current professor of osteopathic medicine here at Western University of Health Sciences.
Yeah.
After a few other academic stints, if you will.
Yeah.
One, if I recall correctly, a 7-year stint at Michigan State University.
Yeah.
College of Osteopathic Medicine.
Right.
And prior to that in New England. Is that
Yeah, the
correct?
University of New England at the osteopathic school there. Yeah.
Great. So my apologies for
Oh,
that
that's okay.
oversight.
I also have powers of invisibility that I use at night for good. No, I don't. All right. So soft tissues and fascia, a little stiff around the shoulder. I'm going to do this technique, which we can do this way or lying down, but I'll do it seated so we can see it a little bit better. And I'm just going to, in the fossa here with the upper end of your humerus, test superiorly and inferiorly and sort of anteriorly and posteriorly. and some rotatory motion. And so I want to bring it, what I want to do is find out which ways in these sort of planes of motion your shoulder joint wants to move more freely. So I can bring it inferiorly pretty well, and I can sort of rotate it internally a little better than externally. And anterior and posterior goes a little better anterior. So I'm going to gather those three planes go in those three directions, and I'm going to hold your shoulder in that direction. And this is a technique that's directed towards the muscles here to some extent, but primarily to all the fascia that invests these muscles. And the fascia moves a little more slowly here, but it gives a sense that people like to describe as an unwinding sort of feeling. So we know that there's some tension in the fascia here, and it's trying to slowly resolve itself here in these ways a little bit.
Right. And it feels like you're getting a good additional exam on my axilla and the other
Yeah,
soft tissues relative to, following up to the malignancy.
Yeah, this is, yeah, thank you for saying that, because it's an automatic thing in my mind. I know that I've palpated into your sentinel fossa here. I know that I'm palpating into your axilla, and I am paying attention to that as I sort of focus on your musculoskeletal complaint here, but I'm looking at sometimes musculoskeletal complaints are part of a presenting problem when we discover these things. So we know in your case that we've kind of taken care of things, but
Right.
this is a residual kind of restriction from what you've been through in the surgical procedure and stuff. And it's a matter of just freeing it up so that you get this last little bit of physiologic motion back in this area.
And what about the people that express some concern about doing manual medicine like this in the setting of a history of malignancy in the, that general vicinity, obviously here in the elbow, but the idea that moving tissues around might in some way engage the lymphatics and facilitate, a metastatic kind of process. What about that?
Well, that's a topic that's been thought about and has been discussed off and on and still periodically within the profession, but there's no great resolution to it. We know that there are malignancies that are spread through lymphatic spread, for example, or through tissues. And so people have raised the question sometimes, say, well, is it good for us to do these kinds of treatments, moving these tissues around? Are we risking a spread like that? Well, on the one hand, you might say logically, it would seem like, well, maybe so. On the other hand, just the fact that you are feeling well and you're up and around and functioning, and we know that just in the activities of breathing and moving and just going through your workday, as you move your musculoskeletal system, you are moving the major pumping mechanisms that move your lymphatic fluids. So is this any more risky than you simply being alive and breathing? Right. And would we ask you to stop breathing and stay perfectly still in order to prevent this? So we can think about that. And we don't know of a good way to try to study this in some scientific way. But there have never been any reported cases that were known to produce any problem like this. So, and the profession has been doing these types of treatments for somewhere in the vicinity of 140 years or so now. So, and so the sort of consensus of experts in our profession on this is they're aware of this, and on an individual basis, case by case, they might come up with some reason where they feel like it's not a good thing to do. But for the most part, almost all the time, we feel comfortable in proceeding with the treatment. It can help improve these kinds of functions. If you have someone that's more ill with malignancy, even terminal, maybe, they're in more pain and other things. They're at that point, they're very ill. And so even if it's just for comfort, we can reduce some of the pain and discomfort that goes along with that. And while we do anything we can to keep them comfortable, including the usual pharmaceutical methods and things, sometimes this type of treatment can help reduce the need for that or avoid some of it. So if that results in the patient being able to be alert and up and around more, not have, or if they have adverse effects from pain medications, that makes it hard for them to take them in the first place. And this helps alleviate the pain. Then we have one more better tool, if you will, or one more good tool that helps the comfort level of people, and we can give them that part of the quality of life in this issue as well. Right. I'm feeling around your elbow, taking some of the tension out of there, and I'll check this.
Yeah, it gets really sore in there, and that really was when I came out of the soft cast, which I was in for a good month, and came out with an atrophied arm and barely able to move my elbow. That particular area has been.
Yeah, if I look at your elbow here, I can sort of. Let me see it enough. There we go. Yeah. Perfect. I can pronate the elbow a little bit like that. And when I try to supinate it, should be a little more, yeah. So what we can do with that is I will, with my thumb, it's hard for people to see here. I'm trying to turn you a bit, but my thumb is right on the radial head there to stabilize that and feel the motion of that bone. And so I'm going to supinate his hand as far as I can, his forearm. And I'm going to ask you to rotate your forearm towards.
Yeah, there we go. There we got it.
Good.
Ooh, that feels good.
Yeah.
See, I can't do that myself.
Yeah, it's something that you can't do very well by yourself. Yeah.
Right.
Rotate it again. There we go.
And I was referred to, for therapy, etc., but to go to physical therapy, and the logistics of getting there, and all of that, I just. So it was like I just don't have the time for that. So I
it's kind of
appreciate
hard
you
sometimes to do.
doing that. Yeah. Ooh, that feels better.
Yeah. So now we can bring that supinated arm up better than we did before. So all these things are going to take some of this little myofascial tension out of this whole elbow, upper arm, upper chest area, allow for better venous and lymphatic flow through there, which clears all the metabolic waste products in your interstitial tissues physiologically. And that, from a clinical standpoint, tends to help reduce any swelling, although we don't see a lot of swelling here, but also tends to take that irritating sort of feeling out of the tissues, all those metabolites building up in there and that type of thing. And should give you a better feel of range of motion. Otherwise, I think your strength, like you can squeeze my fingers, is good. And can you push against me there? Okay, and pull against me. So these other muscular tissues and things are good and strong.
I've been working out quite a bit.
Okay,
trying to do 100 push-ups a day and free weights and things like that. And then I get out in the water every now and then and paddle around a little bit in between everything else. I do have a question also about another motivation for becoming kind of back underneath primary care, is the frustration of dealing with the healthcare system is just, if not depressing, just immensely frustrating and very expensive.
Yes.
And for instance, is every time that I need to have these additional scans done, I wait for the doctor to make that order.
Mhm.
That order then goes into the imaging center. The imaging center then checks with the insurance coverage, et cetera, and inevitably gets back and says it won't be covered because this is a rare tumor and there's no protocol under the
Oh,
insurance
okay.
plan,
Yeah.
and the codes don't match up for any kind of coverage.
Yeah.
So then there's a process called prior authorization
Right.
request.
Yes. Yeah.
And that can sometimes take months
Mhm.
to occur. And I know early in my adventure with this, that right at the beginning, that was strongly recommended that I have a PET scan, a
Yes.
positron emission tomography scan.
Right. Yeah.
And went through that process, but there was some urgency to get that because the surgical management couldn't be scheduled and done until they were assured that I didn't have remote disease,
Right. Yes.
distant disease, metastases.
Yeah.
And the frustration came to the point where I simply scheduled at the imaging center and said, I will pay for it directly,
Yeah.
not knowing that when I got there, that the fee would be $13,000
Okay.
for a
Yes.
PET scan.
Yeah.
But
Yeah.
because I was paying directly out of my pocket,
Yeah.
they gave me a 50% discount.
Oh,
So
okay.
I only paid $6,250 for my PET scan.
It's still
I'm lucky that I was able to withstand that,
Yeah.
financially for myself, but it really reinforced what I think many of us hear about how things go with the firewall of cost
Yeah.
of healthcare and high technology, as well as some of the dynamics of the insurance companies, and
Yeah.
including my own, that follows protocol. And when you have a rare condition, there is no protocol. And if there's no protocol, there's no coverage
Yes.
for these technologies.
Yeah.
So I just wanted to make sure that your office would be able to help manage that frustration as we walk through these follow-ups and these scheduling more scans. and so
Well,
forth.
to be straightforward, I can tell you that we experience the same things with other patients and we understand it. I don't know if I can cure it, but we do think that we can provide a little more impetus and help, not like we're that powerful, but the fact that we'll be your primary care source to try and be the centerpiece of coordinating this thing, and I can coordinate with the other specialists who will want to have these scans and see. And so a little more communication, maybe a little more, I know it's a little more work on our part, but I believe this is something we owe our patients. And it may mean that we take the time to make a few more phone calls and do a little more lobbying at times. And it's not a perfect solution, but it does push things along faster sometimes. It can help get some of that sort of red tape out of the way.
Right. Yeah, because I just can only imagine what it must be like for folks that don't have those resources.
It's for any of us as physicians who get an illness of any kind and have to experience the system that we sort of work with and for, or they might say against sometimes, I don't know. But for us to be the patient versus the physician gives us I know my own experience in these regards has not been as much as yours, but it gives you a different understanding for what your patients have to go through. And for me, in part of my sort of osteopathic philosophy training gives me another level of empathy for. I have sick people who are frightened, scared, concerned, and having to deal with some, systematic kind of things. And just as I feel like it's my job when I discover something wrong with them to make sure I do my best to get them to the right specialty cares if I need consultations and help with the treatments, that I help to steer them directly to the most appropriate people so that they're not looking around, bouncing around for the right people for some time. I think it's part of the job to try to ease their discomfort with this as much as we can, to let them know. I suppose in a way it's a little analogous to the attorneys who take care of people with accidents and injuries. They're suffering too. And I think part of their viewpoint is, let us help you with this insurance maze and this legal maze and this and stuff like that. I would think the same thing. I don't know anything about that. I'm here having, so I feel like just as I want to be as up to date as possible and hopefully give the right care and get my patients to any needed specialty care in the most direct, appropriate way possible, with the economic issues associated with the care. Can I in my office provide some type of assistance or guideposts with that as best we can, so that you're not just left alone and say, well, I don't know, fill out your insurance forms and hope for the best or something like that. That's kind of part of it, but I think we can hope a little better than usual. So yeah, we won't have a perfect way out of that maze, but I feel like we've helped patients at least.
I appreciate
so
that.
Definitely we'll do anything we can. Any kind of time you have a question or a concern, let us know, because if we can connect you up some way, we'll do it.
I feel great. Okay, seriously, I can move better and feel less of the symptoms that we started with. Just
and I think now
today.
everything like walking, weightlifting, surfing, things should, it should feel more normal to you. We may need to treat you a few times or something like this. We'll see. But in the meantime, if you're feeling better now, that's a good result.
Right. So as I go out of my patient note, thank you so much for
you're welcome, sir.
For your attention to me
Give
today.
my regards to your lovely family.
Yeah, thank you. And we may have some questions from the audience, and in particular, we, as Global Offsite Care, and our focus, our mission is supporting telemedicine and telehealth for the underserved. And I see we have a number of our partners here today in attendance. Thank you so much for your interest and time on that. And do we have any questions? We have a few minutes, about 5-10 minutes.
Yes, I actually have a question for you both. So with respect to telemedicine and osteopathic medicine, say this particular interview had been conducted over a virtual platform, what would be some of your recommendations for kind of more home-based OMM treatments that a patient could do for themselves for this type of an injury?
Doc?
Well, there are, we'll start with the standard things that most anybody would expect, is that there's usually some exercises and things. In this case, in Dr. Pecchia's case, I would say that he's already doing some things that I would, where he mentions weightlifting and even the surfing and things, are kind of activities that would help him maintain a certain amount of muscle tone. But I also want those muscles and tissues to be flexible. So I'd like for him to be doing some stretching. So common stretches that you might think about for the cervical area and upper thoracic area, that you can find anywhere are good. A couple that I think are not readily thought of sometimes is, particularly for this, I like to see this, particularly mid to low cervical thoracic area, be pretty flexible and supple, so that they're not tightening up here, and they're not getting kind of stooped shouldered and getting protracted here in the shoulders and kind of creating that tension in these areas. And so one is, I'd ask people to bring their arms up like this, sideways. And what I want him to do is, I want him to squeeze his shoulder blades together in the back. And in fact, I want him to if I hold his arms here, squeeze your shoulder blades without kind of squeezing your arms, kind of try to focus right on your shoulder blades. It's a little harder, but you feel like those shoulder blades are going towards the midline. And that, if you can do that, and then just squeeze that and hold it for 5 or 6 seconds and relax, and maybe do, 5 to 10 of those, do them a couple times a day if you want, it's, so that does a couple things. It opens up this whole area posteriorly, it keeps the fossa open a little bit better and the rib cage moving a little bit better. And it keeps the posture a little more upright, among other things, which is helpful. And then another one for this area, particularly that'll help work the shoulder and whole arm area along with the rib cage, is you've seen the typical exercises they give for people with a adhesive capsulitis, where they stand by the arm and they kind of walk their fingers. Well, if you can do it, I'd get them against the wall someplace and get right up against the wall with that arm a little bit, step out a little bit like this. I almost look like it with the wall back here, and just kind of lean into it, and it's just going to take and side bend. You can even try to reach up the wall.
Like if you were the wall right
Yeah.
here.
And then you would just kind of lean, and it's this whole area right from the lumbar all the way up through here into the arm is going to stretch out, so it's an easy one. A third one that I think you can understand from the description when we were showing this one with the shoulder blades is, if people like it a little better, I have them get into a corner of a room where there's a corner, so they can stand back and put their arms in. You can lean into the corner. That really allows you to relax this area back here while you stabilize yourself. So to me, those are some areas that really work up loosening this and really work on this whole myofascial structure through here, which is where I see the tightness, if you will, or it's not so much joint restriction. In his case, it's more of that kind of soft tissue restriction. So this would be a way to keeping those tissues stretched and flexible, while his other activities actually work to keep them toned. So you get this balance between stretching and toning these tissues.
Wonderful. Thank you so much.
I think I'll do
It is a
more
point
times.
to make, and I try to make with all my students too, and that is that osteopathic manipulation, obviously I'm biased, but it works well. It can be very dramatic sometimes with people, but also at the same time, to be truly osteopathic, not just diagnosing these things, what we call somatic dysfunctions, and just treating them with the manipulation. It's what happens afterwards. So can I help him with some self-care and other, whether it's lifestyle changes or other things he could add into here. What I tell people is my goal is not just to diagnose you and give you the treatment as a doctor. From an osteopathic point of view, I tell them there's 2 questions. One is, what is the problem? Meaning, what's the diagnosis? What's the name of the thing that we've discovered? The other one, so we know how the patient is sick. The other question is, why are they sick? And if we can think of some of these things around it, so that we can come up with ways that he can prevent and maybe avoid some of this stuff in the future, that's where I want to go with him. I kind of, like, jokingly, but I'm kind of serious about it. I tell my patients that my goal is to get you, regardless of what the condition is, to get you to a point where you get healthy and stay healthy and have ways of maintaining that and avoiding problems and things in the future. My goal is to have it so that you don't need me so much. My goal theoretically is to put myself out of business.
Yeah, and actually just following sort of your description, as you see me do those, and I'm doing some of that resistance, and I'm finding the restriction and pushing and resisting and taking that to slack. Yeah, maybe I won't need to come back anymore.
Well, I don't know. It's true. Yeah, we'll find some kind of a preventive test or something you need. We'll drag you back in. but it's a little bit of a joke. But the idea that people get the idea that, like, I'm trying to help you find a way to maintain your health, as much as possible, and wellness, and again, to be realistic, you're going to have people that won't always comply with even your best patients will say, yeah, I was, but then I fell off the wagon with my exercises. So they get that, it happens. And but my ideal sort of goal is that I say, put myself out of business. I know that there's always gonna, people do get sick and we need to help them, but getting them sick and then just giving them the treatment is one thing, but getting them as far beyond that illness into not just health, but wellness is my goal too. So.
Great, thank you.
I have a question to Dr. Shaver and also to Dr. Hruby, if I may. I just wonder if there are any known germline mutations associated with that particular type of tumor that you described.
I don't know myself offhand.
Yeah,
or
that's one
Madeline?
I'd probably have to do a little bit more investigation, look that one up.
That would kind of fall in a context of finding the causes that Dr. Hruby promotes. So I agree with that approach very much.
Yeah.
Yeah. I guess I'll just share my recollection and having seen many experts on this particular tumor, and it coming from the sweat gland cells. It originates from the sweat gland line of cells, and but in terms of causation and etiology, unknown. I had multiple trauma over many years, probably over 40 or 50 years, to that very site. So on the tip of the elbow, so it's right out there. And then of course the sport that I was involved in all those years was surfing. And you've seen surfers and sometimes they fall off. They call it a wipeout, right? And the elbow sometimes will either slam into the hard surface of the surfboard with wax and sand and maybe some bacteria that's embedded in there. So I had a number of infections over the years, right over that same area, sunburns, being in the tropics and so forth, and here in Southern California as well. So, stands to reason that all of that may lead to some change in that cell line that may have initiated a malignant process. But that's about as far as anyone can go with it.
Well, Dr. Pecchia, that's why I chose boogie boarding instead.
That's a really good idea.
One time, it's mostly a constant wipeout, for me.
Right. All right. So I guess I'll thank you all again for coming and being here with us. We'll be posting it. And thank you, Dr. Hruby, again.
My
It was
pleasure.
wonderful. Madeline, that was a tremendous presentation. Thank you for sharing that with us. And with that, I'll send it back for closure to Alexa.
Yes, thank you everyone for being here today. I just reposted the CME link in the chat, so feel free to go grab your CME credits there. If you're interested in presenting, please feel free to reach out. I'll also put my email in the chat, but thank you everyone. Have a great Wednesday.
Thank you.